Hello friends, welcome to the second episode of Medicine with Sherlock Holmes. In last podcast, we saw how Sherlock diagnosed patients with PCOS. In this podcast, we will see what PCOS actually is, why it occurs, and what is possible treatment for it. But here are my two prerequisites before you start this podcast. The first one is go back and please listen to our previous podcast. And the second one is please revise your menstrual cycle notes before starting PCOS. So let's get started with it. It's very simple. So here it is. Now PCOS is an abbreviation for polycystic ovarian syndrome, and it is also known as Steen-Leventhal syndrome. In one sentence, if I have to tell you what is the pathology in it, so it is excessive androgen production from the ovary. Now remember one thing, that excessive androgen production can happen in both in PCOS as well as in tumor of the ovary. So in molecular level, if we see, the androgen level in females normally is around 20 to 80 nanogram per ml, and if this increases but this is below 200 nanogram, then it is called as PCOS. Now remember one thing, what happens when androgen increases. The first thing is hirsutism. Now hirsutism is male like voice, and the second thing which happens is male pattern baldness, and the third thing is heart diseases. The PCOS patient, and obviously males who has excess of androgen, are more prone for heart diseases. Now what happens here is, this excess of androgen which ovary makes gets converted into estrogen. Which form of estrogen? So specifically it is E1 form of estrogen, and it gets converted with the help of aromatase enzyme, and this aromatase enzyme is present in adipose tissues. So what happens here is, in adipose tissues, excessive androgen gets converted into estrogen, which is E1. Now what happens, more the adipose tissue, more are the patient prone for PCOS. So hence we say that PCOS is most common in obese female. Now what happens in PCOS, the ratio of E2, that is estrogen 2, is to estrogen 1 is altered. In normal patient, ratio of E2 is to E1 is 2:1, but in PCOS it gets flipped out, which means E2 is to E1 is equal to 1:2. Estrogen 1 is produced in excess compared to estrogen 2. Now what happens, estrogen is increased. Now estrogen is increased from the start of the menstrual cycle. Now there is 3 effects of the estrogen which you need to know about, which will help you to understand what will be the possible complication of the PCOS. What happens here is, in increased estrogen, there are 2 effects in menstrual cycle. The first one being, there is negative feedback on FSH, which leads to decreased FSH. The other thing is positive feedback on LH. Obviously LH will increase. And the third chance, excess of estrogen. Remember this every time you see any estrogen excess syndrome or disease. There will be increased chance for endometrial hyperplasia or endometrial cancer, breast cancer, or ovarian cancer. Now you can see here, in nutshell, if I have to tell, increase estrogen causes decrease in FSH and increase in LH. Normally what happens in PCOS, FSH is to LH is equal to 1:2 or 1:3, which in simpler words, if I have to tell you, LH is more than FSH. Now to see the test for detecting LH and FSH, test is done on day 2 to day 4 of menstrual cycle. Now let's get back to what happens when LH increases. Now the first thing is, you need to know that why ovulation occurs. Ovulation occurs because in the mid of the menstrual cycle there is LH surge. Now please know this, in PCOS LH surge is absent. Reason? Because LH is increased from the start of the cycle. Remember I told you that estrogen start increasing from the start of the cycle. Now what happens? LH surge is absent. Continuously elevated levels of LH will lead to anovulation. The second thing which is going to happen, LH stimulates theca cells, which leads to theca cells hypertrophy, which again leads to increased androgens. Point to be noted here is androgen will never increase beyond 200 nanogram. Anyway, so what goes here is the patient is having anovulation and increased androgen. Anovulation will be responsible for infertility. Now ovulation is not happening, so there will be no corpus luteum. Remember one thing, corpus luteum is the source of progesterone. So no corpus luteum, less or absent progesterone. Now this leads to multiple follicles appears like cysts in the periphery of the ovary. On USG you will see necklace pattern. Now I want you to remember few things about here, that no corpus luteum causes secondary amenorrhea or anovulatory cycles, which are irregular and painless cycle. So the first thing which anyone should come to their mind is that why there is increased androgen production from the ovary. So it goes as because there is localized insulin resistance. Insulin causes, remember this, insulin causes increased androgen level. Now what happens? You already know what happens after the androgen gets converted into E1, that is estrogen. Estrogen causes negative feedback on FSH, positive feedback on LH, and the positive feedback on LH causes anovulation and increased androgen. Now comes to FSH part. Since there is decreased FSH will not recruit further follicles, which leads to, we have in a nutshell, increased LH, which is responsible for anovulation, decreased FSH, which is responsible for causing no more recruitment of ovules. So what happens here? We have a PCOS patient, and what are the general investigations we do for them? Now remember one thing, we diagnose patient with Rotterdam's criteria, the same criteria which Sherlock Holmes used to diagnose his patient. But for the sake of completion of the topic, I will be going in the flow of investigations as well. So the first thing you need to know is, in investigation, what are things needs to be covered. So there is a ratio, lots of ratios here. Serum fasting glucose level to serum fasting insulin level is less than 4.5 in insulin resistant case, and also serum insulin level will be more than 25 IU. Now you can see here that these are the basic investigation which we can do in PCOS patients. But PCOS is such a common condition, we can simply diagnose it by using the simplest of the criteria, which is called as Rotterdam's criteria. Now remember, for Rotterdam's criteria, you need to follow just two of the following diagnosing criteria. There are three diagnosing criteria, which is hyperandrogenism, ovulatory dysfunction, and USG evidence of PCOS. Not all three needs to be satisfied. Only if two of them are satisfied, the least should be two. Okay, so 2 out of 3 if are getting satisfied, you can diagnose patient with PCOS. Now what happens in hyperandrogenism? Clinical feature of Histidism is seen. Biochemically, if you have to say, then there is increased androgen level in body. Second thing is ovulatory dysfunction. Now ovulatory dysfunction can be seen as amenorrhea irregular cycles or menometrorrhagia. The third point is USG evidence of PCOS. Now you can see it in one ovary or both ovaries. So it is more than 12 follicles in ovary. Follicles should be less than 1 centimeter in size, possibly between 2 to 9 millimeter. Volume of the ovaries should be more than 10 cc. Now there are few misconceptions which are usually seen in Rotterdam's criteria, and which I'm sure that even you will come across when you will hear the first podcast. The first thing is obesity is not a diagnostic criteria. Okay, obesity is the risk factor. More the adipose tissue, more androgens will get converted into E1, that is estrogen 1. Second thing, LDL and HDL ratio is not a diagnostic criteria. I hope you remember that PCOS patients are more prone for heart diseases, and LDL to HDL ratio is used for diagnosis as well as prognosis of the same. Now PCOS can be seen in thin females. PCOS most common is seen in reproductive age, but can be also seen in pre-pubertal age group. PCOS is familial inheritance is seen. Now most common gene mutation, if you want to say, is CYP21 gene. Now also, if you remember, due to excess of LH, we can see necklace pattern on USG. But guys, remember this, necklace pattern on USG is not the diagnostic criteria for PCOS. Ovaries can be normal on USG. So in our case, when we see what we see in first podcast, Sherlock never did USG because Sherlock was sure that the patient is having hyperandrogenism and ovulatory dysfunction. So I'm pretty sure about that. The third criteria, that is USG, need not to be followed here because 2 out of 3 are already satisfied. The second thing is, I want you to know are the complication of PCOS. Why PCOS is such a important disease? Because there are short-term complications with it. The first one, we will go with short-term complications. Short-term complications include infertility, Histidism, and irregular cycles. And this long-term complications are heart diseases, endometrial carcinoma, breast cancer, ovarian cancer, diabetes mellitus, and the obesity causes, which are basically depression, metabolic syndrome, and sleep apnea syndrome. And the seventh one is non-alcoholic steatohepatitis. Now remember one thing, osteoporosis does not occur due to increased estrogen. Now let's get back to the management of the PCOS. The first step and the most important step of the PCOS is weight reduction. And let's get back to the complication and their treatment. The first one is insulin resistance. Now insulin resistance can be treated with metformin. In fact, metformin is the drug of choice for it. And most common complication involved with metformin is GI involvement, and most dangerous complication is lactic acidosis. Now suppose the patient comes to you and I'm not considering he is PCOS patient, but just any other patient who is on metformin and have just conceived. So will you advise patient to stop the metformin? The answer is no, you won't, because metformin is non-teratogenic. Now the second complication is irregular cycles. For drug of choice of irregular cycle, always remember, is OCP. And here progesterone should be of 3rd to 4th generation. Now the reason why we use 3rd to 4th generation is because 3rd and 4th generation are anti-androgenic. The 1st and 2nd generation of progesterone are androgenic, and already patient here is with lots of androgen in body. So it's better to use 3rd and 4th generation of progesterone. Now the third one here is Histidism. Now Histidism as a complication, drug of choice is again OCPs. Now progesterone again should be of third or fourth generation. And the fourth complication, which is infertility, and it is obviously due to an ovulation. The first line of treatment here involves letrozole, which is also drug of choice, by the way. And if you cannot give letrozole, the second best drug is clomiphene citrate. Remember here, letrozole is the drug of choice, not clomiphene citrate. And drug of choice in PCOS, if you have two options, letrozole and clomiphene citrate, go for letrozole. And what about if drug of choice is on obese and insulin resistant patient? Not necessarily PCOS. Again, the drug of choice here is letrozole. Plus, you will also give metformin because here patient is insulin resistant as well. And drug of choice in patient with increased prolactin levels. Here, the drug of choice, please pay your attention carefully. Drug of choice in PCOS patient with increased prolactin level is clomiphene citrate plus bromocriptine, because bromocriptine is ovulating inducing drug and it also reduces prolactin levels. Now this was the first line of management. In first line of management, we just gave drugs. Okay. Now what happens if drugs are not working? The patient is still infertile, has not conceived. Then we go for the second line management, which is human menopausal gonadotropin or laparoscopic ovarian drilling, in which theca cells of ovary is destroyed. Okay, so in second line management we go for HMG, which is human menopausal gonadotropin, or we can go for laparoscopic ovarian drilling. Here theca cells are destroyed. Now if you are paying close attention to this podcast, you will know why theca cells are destroyed. Now the reason being because theca cells are hypertrophied, and hypertrophied theca cells are responsible for excess androgen production. And the third line management here is synthetic GnRH in pulsatile manner. Now that's it for PCOS. I hope you enjoyed this podcast, and if you have any suggestion or any request, please ping me on my Instagram handle, which goes with the name of Medicine with Sherlock Holmes. Bye bye.